Thank you, everyone, and thank you for the opportunity of speaking today. This seemed like a really good idea when I was back in the office, and I rang Jenny and said, guess what, I'm going to put a paper together and I'm going to present at the conference. And when I got accepted, I thought that was fantastic. Now I'm here today, but anyway. So the heading, it's a long heading. We're light on time, so I'll be able to keep it succinct after the heading gets through. I just wanted to highlight that people can live in the bush and still receive care and still have their motor neuron disease and their families looked after very well. And I think we've done a fairly good job, and that's why I've come on behalf of a team, of which there's quite a few, and to showcase that we did a good job. For those of you that don't know where we are, I'm in Victoria and I'm over in that far corner in East Gippsland. We're a large rural area with a population of about 20,000 people, but we cover about 40,000 square miles, which probably for Queensland's not very big, but for Victoria it is. So this is Jerry's story. Jerry, and that's not his real name because the family were a fairly private family. They were happy to have their story told, but they didn't want their names. So Jerry's story was that he was a young fella. He was only 50, in his early 50s. He was working, he had his own private business, had a couple of fellas working with him. He travelled around a lot of Victoria, rural Victoria, doing ATM machines, maintaining them, doing IT work for all sorts of people. He started becoming a bit tired, his legs were a little bit weak. He put it down to sitting in the car and travelling so much. And he said that was just because he was overworked. His wife put it down to the fact that she thought he was just getting lazy and he didn't want to be driving and he wanted her to pick up a bit of extra work. And the kids, they just thought Dad was complaining all the time. He had two teenage kids. One had just finished VCE, was doing a traineeship, and the other one was doing year 11. So both kids were sort of, they had other things to do rather than think about what was wrong with Dad. His medical story, he was one of the lucky ones who actually got a medical student to see him because the medical student had just done neurological diseases, and someone had actually mentioned motor neuron disease when they were doing the lecture, and so Jerry was chuffed into the side room so that the medical student could get a better history, and she went back to the GP and said, I think this man's got motor neuron disease and I think he should go to Melbourne. And the GP went, yeah, right, okay. But anyway, he did end up going to Melbourne and he was diagnosed about 6 months later. So medical students do have their benefits. So along with the diagnosis came the team. And as David said, there's always lots of people involved when you first are diagnosed with motor neuron disease. And this was just our local team, really. We've got the local hospital, we've got the metropolitan hospitals. Melbourne, for where I live, is about a 4-hour drive to our main Calvary, Bethlehem Hospital. And we had community services, and I fit in down into the community services area with Baptcare. So as you can see, there were lots of people involved with him. The GP, we also have motor neuron disease. Victoria has regional advisors. Our regional advisor for Gippsland, Jenny's in the audience here, is a great support and was a big part of the team as well. Our local hospital is Bensdale Regional Health Service, and their involvement, as you'll see in further slides, was both acute and community services. Baptcare, they were called community aged care packages up until the 1st of July. They've now been changed to be called home care packages. Primarily in Bensdale, we only do aged care packages. Jerry obviously didn't fit into that age group because he was under 65. So we had to go through DHS to get authorisation for him to be eligible for a package. And then we had our local community health centre who had palliative care practitioner candidate who was involved. I've put in a slide here about case management because that's the role I do, and I think it's a really important role in managing many clients. It's one person for a family to liaise with. It's a focal point to then go off and find out information to take back to the family instead of them having to find where services might need to come from or where equipment can come from, whatever it might be. So my first question, once we got our DHS approval for Jerry to come onto a package, I came across Jerry partly because we're a small community and I knew him, and also because I was case managing his father-in-law. And his father-in-law said, you know, I've got my son-in-law who's just been diagnosed with this disease and we don't know what it's about and you know, what help can he get? So it was through that and through contact with Jenny that we were able to get him onto a package. And when I went out to Jerry, his first question to me, which I thought was a pretty powerful thing, I said to him, what's the most important thing you want to get out of being on a package? We ask that for all our clients, and they usually say, oh, I want my house cleaned, or, you know, I want to be able to go out for a cup of coffee. But Jerry and his partner's first comment was, we're sick of talking to so many people and having so many people contacting us all the time. We just want someone to stop that happening. So that's what we tried to do. So how did we handle Jerry's request? The slide earlier showed that there were lots of people involved, both from Metropolitan and locally within the community. Prior to me coming on the scene, he was involved with the occupational therapist, speech therapist, dietitian, social worker, the GP, all of them at the local hospital. They were all visiting him weekly, but they weren't doing it on the same day. They'd ring up and go out on different days because they couldn't all fit in the one car. They had to book the car, they had outpatients, they had inpatients. So to get there all on the one day didn't really work. So the hospital had been involved in a project on shared care and care planning support meetings. They had started that when Jerry had first been diagnosed with his motor neuron disease, but those meetings were to get everyone together and talk about what was happening with Jerry and then formalise a plan to go out and do it. But it was still not quite getting everyone to coordinate care. And then when Jerry came on the package and we were able to have case management, we were then able to coordinate it so that I became the focal point of going out and giving the information out to Jerry or taking it back into the team the next week so that we could minimise some of the visits that were necessary but unnecessary the way they'd been happening at LIB. So it was an all of the team case conference. We all got together once a week. The meetings usually only took about 15 minutes, maybe 20 minutes max, where we would all sit around the table, discuss what had happened during the week with Jerry, what was progressing with his disease, what he was wanting to get out of it. His wife also attended those meetings at times. Jerry couldn't always get there, so his wife would come in and be part of the team meeting so that she could say, well, you know, we don't want any visits this week because we want the house to be quiet, or if you all come out on Thursday, then that'll suit us really well. So we were able to look at what Jerry and the family really wanted and fit in around their needs. And we formulated a plan. That's probably too big for you, too small for you to all read, but that's just a copy of the plan where it has all the people involved in the team. You'll see on it that it's got the kids, his teenage boys on it as well, because they provided care to Jerry to allow his wife to have a little bit of time out as well. There was myself, all the allied health team. The GP was always invited, but he usually couldn't get there. So this plan, we would write up what the goals were for the week, and then it would be emailed around to everyone, including the GP. Jerry also got a copy of it each week, so that he could see if there was anything that he wanted added into it. This page shows this was where we wrote down the key issues, so whether it was that he needed a new piece of equipment for the day or for the week, whether his peg feeds needed some sort of alteration, whether he wanted to go to the footy. His boys played footy, so we had to look at how we could get him out with his peg and his NIV and his electric wheelchair and get him to the footy. So all those sorts of goals were fitted into this plan as well. And this page is Jerry's page, where he could put on what he wanted to achieve out of it, or what his family wanted to achieve out of it as well. If anyone wants a link to the plan, it's on the bottom there. Jerry's disease progressed fairly quickly. He started getting symptoms in the November. He was diagnosed in the February, and by the following November he was using all his, he had NIV, he had PEG, he was well and truly into his wheelchair, and he was down to using his light reader, and most of the time his wife was ending up doing the messaging for him. They had such a connection that he could just glare at her and she knew which word to put on the machine. So it came time where we could see that the wife was getting very tired. Jerry was starting to develop a little bit of rigidity in his thought process, and he couldn't see that she needed a break, and he couldn't see that why the boys needed to go to footy training and not come home and give mum a break as well. So we looked at what we could do for respite, and because of his complex care, it was agreed by the team and by his wife that he wouldn't really be able to be managed in an aged care facility within our area, because his needs were too complex. He had the option of going back to Melbourne, to Bethlehem, to their respite unit, but he didn't want to do that. He didn't want to leave home because he was still getting visitors coming, he still wanted his boys around, so we had to look at how we could manage that locally. So we went back to the shared care meeting, and that time we included the acute care staff at the hospital and asked them whether they would consider doing respite within the hospital, which they said, no, we don't do that, we only do acute care. But we put forward a case that if they didn't do it as a respite, planned respite, then he would end up in as an acute patient. So it worked. So we got him into hospital. After planning, we had a couple of quick meetings where we got all the team together. We then started involving the palliative care team, and we used one of our community carers who was seeing him in the home and doing personal care. She actually went into the hospital with the hospital's permission and provided care for him as well. We were able to get funding through MND Victoria to send his wife away on a few days holiday, and we also were able to access some funding to provide one-on nurse support while he was in the ward for his stay. So he actually had a very positive 7-day stay in hospital. The nursing staff, prior to him going into hospital, I went up, did an education session, gave them the care plan of how he was being managed at home, so that they were all familiar with it, and did a couple of education sessions on motor neuron disease with them. And we got him into hospital. So when it was time to say goodbye to Jerry, he was already had been in was going to die at home, and then at the last minute his wife said, no, I can't stay in the house, got boys, teenage boys, we can't get rid of this property, so he can't die at home. So Jerry ended up needing to go into hospital to die, and it worked well because he'd already been in the hospital. The nursing staff were familiar with him. He had become familiar with them. His wife actually had her birthday the day before he died, and they put on a big party for her. They allowed music to come in. There was a couple of guitars. They had cakes. They had drinks. The nursing staff decorated the room, and Jerry was still able to be all part of that. So it turned out to be a really positive experience, and although obviously he didn't want to die and his family didn't want him to die, it did turn out to be a positive experience. So did we achieve what we set out to? Jerry didn't get to die at home, but his family felt that he'd died as he would have wanted. The family were really pleased that he hadn't died at home, but they were also really pleased that they'd been included in the whole process. And the team, we all felt that we'd done a good job and that we'd had managed to get his wishes met as best we could. And that's just some photos of where we live to showcase our area.